Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us update ourselves with the latest guidelines on the management of adult tuberculosis. This session will be presented by Dr. Malbar Ferrer. He is a member of the Board of Directors and the immediate past president of the Philippine College of Chest Physicians. He is also the founder of the Citizens Coalition Against TB in Iloilo and is the chairman of the Medical Education of St. Paul's Hospital, Iloilo. This session will be moderated by Dr. Miguel Gutierrez.
Good day, everyone. First, thank you to this Tiger Postgraduate course. Thank you for the invitation to be a part of this educational activity and to talk on updates in tuberculosis. Most of the concepts here were sourced from the WHO Global Report dated August 2020, which is all reviewed by the American Thoracic Society. Since the topic of tuberculosis is so broad, I would like to limit my scope on this following topic: updates in the global situation, impact of COVID pandemic, updates in diagnostics and therapeutics, and lastly, updates on the treatment regimen on MDR-TB. This statement from Dr. Donald Emerson, formerly the head of the TB section of the WHO, seems to represent the concept or the perspective about TB, which I fully subscribe to. It is and I quote here, "TB is a strange disease. It is infectious but chronic. It is caused by a bacillus, but also by poverty. It reflects what is currently happening and what happened decades ago. It is exogenous and yet endogenous. Tuberculosis is so complex that it is a collection of conditions rather than a single one. Its visage changes with different settings. Its control requires a strategy that has to be equally varied in its adaptation. An understanding of the natural course of tuberculosis is essential for an understanding of its control. Allow me to share with you this timeline from the time tuberculosis, the agent of tuberculosis, was discovered up to the present. This timeline would give us a better perspective as far as understanding the disease of tuberculosis. 1882, when the agent Mycobacterium tuberculosis was discovered by Robert Koch. From the turn of the 20th century, 1900 up to 1940, it also known as the pre-chemotherapeutic era, the only strategy around the world is what they called as the sanatoria movement, where patients are isolated in a special place and made to feed with good food and clean environment. By 1940 to 1970, the primary drugs for TB during this period was discovered, starting with streptomycin sulfate in 1944, followed by the para-amino salicylic acid and thioacetazone. And then in the 1950s, INH and PZA was discovered to be active for Mycobacterium TB, against Mycobacterium TB. Ethionamide and cycloserine followed. And in the period of 1960s to 70s, two important drugs came out in the market, the ethambutol and rifampicin. The development of rifampicin in the late 1960s brought into consciousness the era of short-course chemotherapy. Several studies done in Africa leads to the development of the short-course chemotherapy in tuberculosis. By year 1980s, quinolone came out in the market. At the same time also, when HIV was recognized as a clinical problem during the 1982 to 1983. After the development or the recognition of HIV as a disease, MDR-TB came out and recognized. From 1990 to 1995, the drug-resistant genes was recognized and identified. CAT-G genes and INHA genes and the GYRA for INH resistance was identified. Other resistant genes for the rifampicin RPOB, RRS, and RPSL for the rifampicin resistance was also recognized, as well as the resistant genes for ethambutol. In the in the late 1980s, DOTS strategy was adopted by WHO and rolled out all over the world as a strategy to control TB. In the early 2000s, PPMB, or the private-public mix, was also introduced in order to get more involvement from the private sector in the fight against TB. However, during this period also, extremely drug-resistant tuberculosis was identified. New drugs or new compound identified active for tuberculosis was also recognized, the PA824 and the R207910. From that time on, the saga of TB continue. In fact, it is now recognized that there is already a superbug they called as XXDR for TB. The WHO released this global top 10 causes of death. If you look at in the year 2019, TB as a leading cause of death is already out of the top 10. In the year 2000, TB is ranked number 6, but it was reduced to number 10 in 2016 due to the attention given by the WHO and the funding provided by the different institutions. Although TB is still one of the big 3 infectious diseases that is a problem all over the world, together with HIV and malaria. However, if you look at the low-income countries, TB is still on the top 10 as the leading cause of death among the low-income countries. Here, it is number 8, and the low to middle income countries, TB is in number 7 among the leading cause. For the high-income countries, the non-communicable diseases predominates the top 10 leading cause of death, and only one, the lower respiratory infection, remains in the top 10 leading cause of death. All are the non-communicable, mostly lifestyle diseases. So the global TB situation on this WHO report published in August of 2022 recognized that in 2019, there are 7.1 million reported to have newly diagnosed TB, compared with 2018, which is 7 million. Combining the two, you have 14.1 million newly diagnosed TB, which is 35% of the 5-year target set by the WHO. As to geographical distribution, higher incidence rate is seen in WHO region of Africa and Southeast Asia, primarily in India and Indonesia. Higher incidence, of course, is seen in low-income and lower middle-income countries. Age and sex distribution, 90% of the cases were seen in the age group greater than 15 years of age, and mostly predominantly among men at 58% of the cases, seen 34% in women and 8% in children. The male to female ratio is 2:1 for patients 45 years old and above, while 15 years old and below, there is a 1:1 no sex preponderance. Drug resistance also increased from a report in 2018 to 2019, an increase of around 10%. Why is TB still a challenge? Is the diagnostic a problem? Indeed, clinical presentation is so varied. In fact, from being asymptomatic to the worst case scenario that it looks like a cancer, the clinical presentation of TB is so protruding. In fact, TB is called the greatest mimic. Bacterial deconfirmation is likewise challenging, as much as the simple sputum smear microscopy, which is the hallmark of TB diagnosis, is only around 30 to 40% confirmed positive on even with cavitary TB on chest X-ray. How about the treatment? The challenge is too many medications, too long to take, and too many drug reactions, interactions. Patients, psychological, attitude, educational, concomitant presence of concomitant disease, as well as the financial aspect also influence TB. How about the TB bacilli? The genome has been unlocked in 1998, and we definitely understand more about TB by this time, but still TB continue to be a challenge to us. This is the caricature of mostly elderly who suffers from the reaction to anti-TB medication, who tends to stop or to avoid TB medication, and this affects compliance to medication and leads to the continuing problem of TB. The end-TB strategy of the WHO and the Sustainable Development Goals stated its vision for the world, a world free of TB, zero death, disease, and sufferings due to TB by the year 2035. The goal is to end the global TB epidemic by 2035. The indicators and milestone and the target was set every 5 years starting in 2020. There should be a 35% decrease in the absolute number of TB deaths by 2020, last year, 2025, 75%, and up to the end of TB projected to end in 2035, where 95% will be saved from TB death. Percentage reduction, and the TB incidence rate is also stated in this slide. The overview of progress towards global TB target, the Sustainable Development Goals and TB strategy targets for reduction on the TB incidence rate and TB deaths and catastrophic cost is projected in this slide. TB incidence, the target from the year 2015 to 2020 is 20% reduction. However, reports showed that we only reached 9% reduction. The number of TB deaths, the target is 35% reduction with the same year for 5-year interval, 14% reduction only attained by year from 2015 to 2019. The percentage of people with TB facing catastrophic cost, which means people who are sick of TB invest a lot of their income to TB medication, which is 49%. TB treatment, people who are sick of TB targeted about 40 million, only 14.1 million was able to avail of TB treatment. The TB preventive treatment, target of 30 million, only 6.3 million were able to avail of the preventive treatment. Funding for the TB program to prevention, diagnosis, treatment, and care, the expected budget was 13 billion, but up to last year, 2020, only 6.5 billion was able to solicit. And for TB research, which is expected to spend 2 billion for the annual research for TB, they were able only to collect 906 million by end of 2018. With these challenges, here comes another problem, came the COVID disease, the coronavirus disease, which turned our world upside down, making the diagnosis and treatment and management of TB more difficult and challenging. I never imagined in my life that a security guard would take the vital signs, primarily the temperature of the physician or other medical professionals. That's the impact of COVID. So how does COVID affect our progress in the control of tuberculosis? This slide showed a case notification graph in India in 2020, before and after the lockdown. And if you look at the black graph, the total, a significant drop for the first 3 months when COVID came into the world. And the public sector and the private sector similarly suffered the same drop in TB notification in India. How about in the 14 highly TB burdened countries according to the WHO? Notable on these 14 high burdened countries or India, where there is significant drop in TB notification, followed by the Philippines, and 2 in the African region, the Sierra Leone and the South African, in the South Africa. Some countries started to increase their notification case, although it's still way below the expected notification rate. How about the impact of COVID-19 pandemic on the global number of TB deaths? Here, the graph on the graph showed the decrease in the duration of the decrease in the as graphed against decrease in case detection and the excess TB death. If the decrease in case detection drops by 25 to 50%, if you look at the blue dots there, as for the next 3 months, there will be a significant excess death for TB by around 200 to 400,000 excess death. And that is due to the impact of COVID pandemic on TB program. Here are some of the list of impact of COVID on TB, on tuberculosis control program. The impact on health service availability, such as there is fewer health facilities providing outpatient as well as inpatient care for people with TB, both with drug susceptible and with multi-drug resistant tuberculosis. There is also reallocation of TB resources from the NTP staff at the national and subnational level, reallocation of funding, as well as the reallocation of the machines like the gene expert more towards diagnosis of COVID rather than towards diagnosis of TB. Some mitigating strategies were also developed. Here is an overview of progress in the development of TB. It is categorized under technologies endorsed by WHO and level under evaluation by the WHO. Notable, if you look at the gold color tiger there, some of the technology, the molecular detection of TB and drug resistance. To summarize this, here are some which is recommended by the WHO as rapid diagnostic test using molecular technology to detect TB among people with signs or symptoms of TB. The most popular, of course, were the gene expert MTB rifampicin, which was introduced in the world and approved by the WHO in 2010. It is expected to give the result at a fast rate of around 2 hours, but at the moment, experience in the Philippines showed that most of the centers that cater to gene expert technology has turnaround time of around 10 days to 14 days or 2 weeks. The sensitivity and specificity of gene expert TB is around 98% for smear positive specimen. However, for the smear negative TB, the sensitivity and specificity dropped to 75%. In fact, for the smear negative cases, there is high incidence of false negative. Another technology is the loop-mediated isothermal amplification test, or the TB-LAMP, which is now utilized even in the provinces. India has developed the test primarily to diagnose TB in the form of TruNA-TM, MTB, and the MTB+. The MTB rifampicin diagnostic test was also being considered. Another test is the lateral flow urine lipo-arabinomannan assay, which utilizes the urine specimen to detect TB. The sensitivity is quite moderate at 50%, while the specificity is quite high at 83 to 100%. However, there's only about 2% utilization of this new technology. The Gene Expert also is planning to come up with Gene Expert Ultra, which is believed to be more sensitive than the original or the early generation Gene Expert. So hopefully we can avail of that. Some Western countries has already done this, but in the highly burdened countries, it's not yet available. So how do we screen TB as of the moment at this time? Chest radiography and chest X-ray is still an important tool for TB triaging and screening. It is also useful as an aid in diagnosis. The major limitation, however, is because it requires experienced interpretation, experienced interpreter, and there is a lot of subjectivity in it rather than objective assessment. The accuracy of TB screening when reading chest X-ray varies markedly, even among specialists. What they called as the inter-observer variability, which could range from 12 to 17%. However, X-ray, if you couple it with symptom screening or clinical assessment, the sensitivity of 74% increased to 96%. That's why up to now, a lot of private practitioners and clinicians still rely heavily on chest X-ray. The chest X-ray radiology, the chest X-ray also recently utilized computer-aided software products, which is developed to interpret digital chest radiograph for abnormalities suggestive of TB. The CAD system incorporates machine learning algorithm that analyze a chest X-ray image and produce a standardized interpretation of the image. The score report is generated that whether consistent with TB or not. The picture here shows me as part of the PCCP team together with Dr. Tina Marañon, who trained for a software developed by the Japanese expert under the auspices of the Japanese government in the form of the JATA Assistance or Japanese Anti-Tuberculosis Assistance for Asia, where they developed a software program known as Medical Shinansa to help radiologists standardize TB diagnosis by chest X-ray. Here is the picture of a very portable digital X-ray machine, which is developed by the Fujifilm company, by the Fuji company. The beauty of this machine is actually on its portability, the low kilo voltage needed, and it can be only mounted in a camera tripod to be used. In Japan, they are using this to go to the places where patients cannot report to the hospital for evaluation of TB. The data and the picture taken by this machine will be connected online and directed to a central system, usually in the big hospitals, in big centers, and be interpreted. The beauty also of this machine is that it will help you, it prompts you on the area of the chest where the disease is most likely to occur. So it gives you the signal, mostly red coded, whether this portion in the lungs is diseased or not. So how about the test for TB infection? We have two methods. Of course, the popular and usually utilized among pediatric patients are the skin test or the TST, and the IGRA or the immune globulin releasing assay. These are the two skin tests for TB infection. How about the IGRA? There are two approaches to the immune globulin releasing assay determination. One is the enzyme-linked immunosorbent assay or the ELISA-based method, and the other one is the ELISA-linked immunosorbent spot. Both of them are good, are better, considered better than the skin test or the tuberculin skin test because they are not affected by the BCG vaccination, as well as patients who are immunocompromised. This is an overview of progress in the development of TB diagnosis. Technologies in development are still abound. The skin test for TB, for example, the CTB skin test and the EC test developed in China is now being developed. These are the developed technologies, no? In the market, but not yet evaluated by the WHO, are the DIA skin test for TB. So how about TB treatment update? Before starting any TB treatment, it is highly recommended that bacteriologic confirmation is necessary, especially to test for drug resistance. The test for rifampicin resistance has already increased globally from 51% utilization in 2018 to 61% of people with bacteriologically confirmed TB as a result of the increased utilization of the Gene Expert machine. Here is the outcome for new and relapsed TB reported by the WHO in 2019. This is with the use of the standard chemotherapeutic regimen of 6 months of rifampicin INH and the addition of ethambutol pyrazinamide on the first 2 months of intensive phase. The overall global treatment success is at 85%. There are countries that reported more than 90%, up to 95%. But of course, the factors that affects the decrease or affects the outcome is because of patients who are lost to follow-up or patients who died. Here are some recommended, and they call it the awkward treatment regimen forwarded by the International Union Against Tuberculosis and Lung Disease. The TB treatment of 6 months is extended to 8 months, and the utilization of the addition of streptomycin in the first 2 months, then sticking to the RH-easy regimen for 1 month, and the remaining 5 months maintenance phase with the use of rifampicin, INH, and ethambutol. Again, this is only a recommendation, but the IUATLD, although the WHO has not recommended this, and would like to reiterate that this is a retreatment regimen. This is the patients who have undergone treatment before, but found out to have active tuberculosis again, but their specimen or the bacteria is still sensitive to the rifampicin and INH via the Gene Expert test. So how about the TB preventive treatment? These are the people who are recommended for prophylactic or TB preventive treatment. Household contacts of bacteriologically confirmed pulmonary tuberculosis, especially the younger ones, the less than 5 years old, and the older age group, people and those people living with HIV and people on clinical risk group. So as far as the global progress in provision of TB preventive treatment in 1918 and 2018 and 2019, the target for all ages is 13 million patients to be given preventive therapy. We only attained 21% of that treatment in 2018 to 2019. The preventive treatment for people living with HIV is quite high at 88%, so we're able to disseminate and to give preventive treatment primarily for people with HIV. Household contacts less than 5 years old, that means children, only 20% were able to avail of preventive treatment, and very much low on household contacts with patients above 5 years old. What are the recommended options then for TB preventive treatment? This includes, in the usually used is the daily dose of INH for 6 to 12 months, or the 12 to 6 months age regimen. This is believed or noted to be have a protective efficacy of 90%, both for HIV negative and HIV positive cases. Other recommendations includes the weekly dose for the next 3 months of rifampicin and isoniazid for 3 months, the daily dose of rifampicin plus isoniazid for 3 months, daily dose of rifampicin plus isoniazid for 1 month, and the daily dose of rifampicin for 4 months. The use of rifampicin plus pyrazinamide was also efficacious, except that there is excessive hepatotoxicity because of the pyrazinamide. How about the challenge of MDR-TB? Globally, MDR is seen in the newly diagnosed cases by about 3.7%. It is also common with people or patients who had undergone previous TB treatment, and they are as high as 20% who are noted to have MDR-TB. And patients who are lost to follow-up is 28% develop MDR or was found out to have MDR-TB. And patients who were treated with the standard regimen and fail on the standard regimen, 10% of them was found out to have MDR-TB. And of this MDR-TB, 9% developed the extremely drug resistant. The treatment success, which is targeted by WHO at 75%, we were able to attain only 57% treatment success for patients with MDR. But that is very much an improvement from the 2009 report of treatment success for MDR at around 48%. Probably this is due to the development of new chemotherapeutic agent that address the MDR problem. The recommended option for preventive treatment for patients exposed to MDR-TB. Moxifloxacin with ethambutol is the preferred one. And the other option is the PCA ethambutol ethionamide and the PA824, but this is less preferred due to the too much medication to be taken. The global clinical development pipeline for new anti-TB drugs and new drug regimen, as reported by WHO in August 2020, showed a significant number of new compounds as well as new studies that examine the validity and the effectiveness of the different trials that is being done as shown in this slide. How about recommended options for TB treatment? TB treatment for rifampicin susceptible but INH resistant tuberculosis. The WHO recommends the addition of levofloxacin, and they recommend for a 6-month treatment that is with or without INH included in the regimen. However, because of the adoption of the fixed dose combination, oftentimes INH, despite its isoniazid resistance, is still included in the regimen. It is not recommended to add streptomycin or other injectable agents to the treatment regimen. It is noted that the success rate were higher when fluoroquinolones was added to the rifampicin ethambutol pyrazinamide with or without INH when treated. And also there is a lower mortality when this regimen with levofloxacin is added. How about recommended options for MDR-TB treatment? The medicine used in the treatment for MDR is classified into 3 categories. Group A includes the quinolones, levofloxacin or moxifloxacin, the bedaquiline, and the linezolid. Group B category includes clofazimine, which is a medication for leprosy, and cycloserine or tioridazine. And the Group C included the Group C are the ethambutol, dilamanid, pyrazinamide, and antibiotics, meropenem, amikacin, and the other second-generation drug. The recommendation for MDR-TB treatment is categorized either as a short course or a long course. The shorter all oral medications which contains bedaquiline containing regimen is recommended for 9 to 12 months for the short course chemotherapy for MDR, for the confirmed MDR-TB. However, it should be noted that as long as the second-line TB medicine used in the regimen does not exceed for 1 month use before, and the resistance to fluoroquinolone has to be excluded before you use the short course all-oral bedaquiline-containing regimen for MDR. The longer regimen for multi-drug resistance or rifampicin-resistant tuberculosis recommends the use of all 3 Group A agents and at least 1 Group B agents to be included in the regimen. These are the recommendations based on the guidelines of the WHO. The intensive phase is also extended up to 7 to 9 months. So a recommended regimen for XDR-TB, that is MDR with an additional resistance to fluoroquinolone and other secondary drugs. A treatment regimen lasting 6 to 9 months composed of bedaquiline, pritomanid, and linezolid used but under strict supervision. Of course, lastly, this is now the different vaccine under trial from phase 1, phase 2A, phase 2B, and phase 3 trial vaccine. The one in the gray is the vaccine which uses viral vector. Those with dark pink are those with using live mycobacterial organism, and the light pink are those which uses the whole cell or the extract of the mycobacterium organism, while the green are the one using the protein of the organism. So I think these are only the selected topics which I would like to share with you as far as the vaccine and the TB. And I would welcome questions after this. Thank you, and good day, everyone.
For this next lecture, let us refamiliarize ourselves with the principles of adult immunization. This session will be presented by Dr. Remedios Coronel. She is the current chair of the section of infectious diseases at the University of Santo Tomas Hospital and the Los Santos Medical Center. She is also the past chair of the Committee on Adult Immunization of the Philippine Society of Microbiology and Infectious Diseases and is the former president of the Philippine Society of Microbiology and Infectious Diseases. This session will be moderated by Dr. Miguel Gutierrez.
My lecture for this morning is on adult immunization. So my objectives are to give you the latest advances and changes in the field of vaccinology using the grade system, which is grading of the recommendation, assessment, development, and evaluation system, integrating expert opinions and evidence-based recommendations, and updates on the vaccines routinely given to immunocompetent as well as immunocompromised patients, and address issues regarding commonly asked questions regarding vaccination in adults. So immunization is the process of making a person immune or resistant to disease through vaccination. So you shall be good immunity, and there are two types of basic mechanism for acquiring immunity, which is the active immunity, wherein you get it through natural infection or vaccination, and it is permanent and produced by the patient's own immune system. Basic passive immunity, you get it from maternal transfer most of the time, and it is transferred from another person or animals, and it is temporary. We have two types of vaccine, the live or attenuated or weakened vaccine, which must replicate to be effective, and usually effective with one dose with severe reactions possible to occur. But the important thing is there is interference from circulating antibody. An example of live vaccines are the MMR, varicella, oral typhoid vaccine, and others. And then we have the inactivated vaccine, which is not live and they cannot replicate and has a minimal interference from circulating antibody, requires usually 3 to 5 doses, and antibody titer falls in time, requiring booster doses. Example of which are your hepatitis B, polysaccharide vaccine, pneumococcal vaccine, your influenza vaccine, and others. Administration, timing, and spacing of vaccines. Vaccines should not be administered at intervals less than the minimum intervals. Diseases or doses administered too close together or at too young age can lead to suboptimal immune response. And in case of multi-dose vaccine, vaccines, vaccine doses administered less than or equal to 4 days prior to the minimum interval are considered valid, and this is called the grace period. This 4-day guideline is not applicable to rabies vaccine schedule because it may interfere in the circulating antibodies and may not give good immune response in rabies because it's a severe disease. Doses of any vaccine administered more than or equal to 5 days earlier than the minimum interval should not be counted as valid doses and should be repeated, and the repeat dose should be spaced after the invalid dose by the recommended minimum interval. Simultaneous administration of vaccines, administration of more than one vaccine on the same day at different sites, and not combined in the same syringe is okay. Any inactivated vaccine can be administered simultaneously at any time before or after a different inactivated or live vaccine. 2 live vaccines should always be administered on the same day, on the same time, and if not given at the same time, the 2 live vaccines be given at least 4 weeks interval to minimize potential risk for interference. If the 2 live vaccines are separated by less than 4 weeks, the second vaccine should not be counted and the dose should be repeated at least 4 weeks later. This is a case of a nurse who has chronic anemia due to abnormal uterine bleeding, and she complained of dizziness. Hemoglobin showed 67 grams, necessitating transfusion of whole blood. After a week, news in the hospital broke out that there was an outbreak of measles among the health workers, for which the nurse wants to have received the measles vaccines. What advice should you give them to this patient? Live vaccines and antibody-containing products should not be administered simultaneously because the live vaccine interferes with the circulating antibody, so there will be no immune response. In this case, the nurse received whole blood, and the recommendation for the giving of the measles vaccine should be based on the recommendation of what blood products should be given. And in this patient, she was given whole blood, for which the measles vaccine should be given 3 months. For platelet, 6 months. However, if you give inactivated vaccine or toxoids, you can give it simultaneously and even at any interval before or after the receipt of antibody-containing vaccine product because there's no interference in the development of protective antibody since inactivated vaccines cannot replicate. This is now the clinical practice guidelines for immunization of immunocompetent adults and at population at risk. For hepatitis A, the recommendation is to be given to all immunocompetent individuals with a dose of monovalent vaccine of 2 doses. This is to be given also to special population like travelers, men having sex with men, users of injection and non-injection drugs, and those with chronic liver disease and with HIV infection. A family of 5 decided to go on vacation at Vietnam at the end of the month, and the question is, what is the best time you can give the vaccine? How soon is the protection? And so, as soon as the vacation is planned, then you have to give the vaccine. If you give the vaccine, there will be protection immediately. However, 99% or almost 100% protection will be developed within 1 month after the single dose of vaccine. In prevention, hepatitis B, it is to be given for prevention of hepatitis B infection among high-risk individuals, those with contact with blood products, blood-contaminated instruments, and others, students, medical dental students, healthcare workers, prisoners, or drug users. May be recommended also to those low-risk individuals, like those more than 15 years of age without history of hepatitis B infection and with negative B markers, and should be routinely administered to patients with chronic renal disease and to persons living with HIV. So your schedule is monovalent 3 doses, or you can give the combined dose of hepatitis A and B at 2 doses. How about those patients with chronic renal failure? The dose should be the so-called reinforced vaccination schedule, for which the dose is doubled, 40 micrograms at 4 doses at 0, first, second, and third months. If say Ferrer is going to Africa in 2 months' time, her employer requires him to have immunization against hepatitis B, and he has negative his immunization history. How can you help this seafarer? So you can give the so-called accelerated hepatitis B schedule at those day 0, day 14, and day 42 days IM, with booster dose given after 1 year, because the seafarer needs an immediate protection and rapid conversion. An award nurse was pricked by a needle used from a hepatitis B patient. How will you evaluate and work up this patient? Review the vaccination history, get the hepatitis B antibody titer. And of course, you have to give hepatitis immune globulin in this patient. If the hepatitis B titer is more than 10, no more vaccine. Herpes zoster vaccine, which is a live attenuated vaccine, and is to be given for immunocompetent adults more than 60 years of age without history of herpes zoster to prevent disease, and also for immunocompetent adults with prior history of herpes zoster to prevent recurrence of the disease. Now, in pregnancy, you should not give it in pregnancy because it's a live vaccine, and in severe immunocompromising conditions like HIV with CD4 count less than 200. The efficacy of herpes zoster virus vaccine for prevention of herpes zoster, as you grow older, the efficacy becomes less. It's only 44%, 41% for prevention of post-herpetic neuralgia. As the individual grows older, the efficacy rate of the vaccine is better, which is at 66%. And for the duration of the efficacy after 4 years is at 44%. Human papillomavirus vaccine, we have 3 types, the bivalent, quadrivalent, and nonavalent. And these are to be given in preventing cervical cancer associated with HPV 16 and 18, the bivalent, among immunocompetent adult females, and can be given up to 26 years of age. For the quadrivalent and nonavalent vaccines, they're effective in preventing cervical cancer and anogenital warts among immunocompetent adult females and males aged 16 to 26 years old. May be given also to adult immunocompetent males 16 to 26 years of age for prevention of anal cancer and genital warts. Does it matter which vaccines given to boys? Yes. Currently, only the quadrivalent and nonavalent vaccines, which provide protection for genital warts and anal cancer, are licensed to males. Influenza virus vaccine. We have the inactivated trivalent influenza and quadrivalent influenza vaccine. Routinely recommended in preventing influenza and influenza-like illnesses in immunocompetent adults, and should also be administered to patients with HIV CD4 count more than 100 to prevent laboratory-confirmed influenza. It is also recommended to prevent influenza-related respiratory infections and hospitalizations in those patients with bronchial asthma, COPD, and cardiovascular disease, and those with end-stage renal disease. And can also be given to patients with cancer to prevent all-cause mortality and pneumonia. This is the efficacy of the influenza virus vaccines. If you give it to patients with end-stage renal disease, you have a 32% all-cause mortality reduction. And with bronchial asthma, this efficacy is 98%, preventing influenza and related asthma exacerbation. For COPD, You have 73% efficacy in preventing COPD exacerbations for cardiovascular disease, 55%. Japanese encephalitis virus vaccine is a live attenuated recombinant chimeric vaccine. It's given to immunocompetent adults, travelers going to these different countries. Schedule is single dose subcutaneously, can be given anytime, no booster dose needed. Because immunogenicity studies showed seroconversion after single dose to be 99% after 60 days with a rapid immune response, producing antibody as early as 14 days of the vaccination. Measles, mumps, and rubella vaccine recommended routinely to all immunocompetent adults for prevention of MMR and as catch-up vaccination for adults with incomplete or no childhood vaccination. Pregnancy with no evidence of immunity to rubella should not be given this vaccine, but should be given after pregnancy, just with 1 dose. HIV infection with CD4 count of more than 200 with no evidence of immunity be given 2 doses of MMR 1 month apart, but not to be given in severe immunocompromising conditions. And students in post-secondary educational institution, travelers, and household contacts, or persons with no evidence of immunity should be given 2 doses at least 4 weeks apart. And healthcare personnel born in 1957 or born before 1957 with no evidence of immunity to MMR should be given 2 doses of MMR 1 month apart. Schedule is 1 to 2 doses given at least 28 days or 1 month apart subcutaneously. And 1 dose is recommended for adults not at high risk for exposure and transmission. Why is a recent blood product administration a contraindication to giving measles vaccine? This is not a safety but an immunogenicity issue. The immunoglobulin in the blood product neutralizes the MMR virus, leading to low immune response, so no full protection. Wait for 3 to 6 months, depending on the blood products that was given. Meningococcal vaccine, not routinely given. We have 2 types of vaccine, the polysaccharide and the polysaccharide conjugate vaccine. Recommendation, not routinely given. An elderly wants to have this, then you can give the polysaccharide conjugate vaccine because of better immunogenicity in the elderly. Adults from low endemic area who will travel to endemic area or hyperendemic area like the African meningitis belt and those going to make a pilgrimage should be given. These are the high-risk groups to be given: those with asplenia, immunocompromised patients, persons with HIV, those with complement component deficiencies and properdin deficiencies, personnel handling Neisseria meningitidis in the laboratory, and close contacts of meningococcal disease. And during outbreak control, you can give your meningococcal vaccine. Schedule is just single dose, sub-Q, 10 days before travel. For high-risk individuals, you give 2 doses, 2 months apart. If the risk continues, then you should have to give vaccination with 2 doses, 2 months apart. Pneumococcal vaccine, we have 2 types, the PPSV23 and we have the PCV13. Both can be given routinely to immunocompetent elderly patients to prevent invasive pneumococcal disease and in preventing mortality. Both are recommended in immunocompetent elderly adults to prevent pneumococcal pneumonia, but the better recommendation for the PCV13 in preventing pneumococcal pneumonia. Schedule, PCV should be given first, followed by PPSV23 1 year after, and no revaccination with either vaccine is needed. 24-year-old male, diagnosed case of HIV with CD4 count of 254 cells. And due to the pandemic, he inquired about receiving flu vaccine or pneumococcal vaccine, either PCV13 or PSV23. What are you going to advise this patient? You can give both vaccines in this kind of patient because both these vaccines, influenza and pneumococcal vaccine, you can give it at the same time because they are both inactivated vaccine. Adult Filipinos more than 50 years old given PPSB first may be given PCV13 after 1 year. Adult Filipino less than 50 years old previously vaccinated with PPSB but now is 50 or more may receive 1 dose of PCV13 at least 1 year after the PPSB, and then another dose of PPSB 1 year after the PCV13. Adult Filipino 50 years old previously given PPSP 23 without PCV13 may opt to be given another dose of PSSB 23 after 5 years, no vaccination thereafter. Age 19 through 64 years with chronic medical condition, excluding hypertension, those with diabetes, liver disease, and cigarette smoking should be given 1 dose of PPSP23. Those patients aged 19 or older with CSF leak or cochlear implant should be given 1 dose of PCV13 followed by 1 dose of PPSB23 at least 8 weeks. This patient reached age 65 or older, administer another dose of PPSB23 at least 5 years after the PPSB23. Only 1 dose of PPSB23 is recommended at age 65 years or older. Tdap, vaccine type, TD and Tdap. Recommendation, adults who have not been vaccinated or incompletely vaccinated with the primary series of TD and Tdap should be given the complete series of 2 doses of TD and 1 dose of Tdap. The first dose should always be the Tdap. Before you can give TD, Tdap, TD. Now it's Tdap, TD, TD. Adults who sustain tetanus-prone wounds should be given TD with or without immunoglobulin to prevent tetanus infection. A pregnant woman on her 3rd trimester of pregnancy consulted you because he wants to have vaccination against tetanus. She never had history of tetanus vaccination. How will you address her concern? All pregnant women should receive the vaccine anytime, but preferably optimal administration should be at the 27 to 36 weeks of pregnancy to maximize the maternal antibody response and passive transfer of the antibodies to the fetus. Give 2 doses of TD at 4 weeks interval, the second dose preferably 2 weeks before delivery, and the 3rd dose or 4th dose 6 months after this 2nd dose. And for subsequent pregnancy, you can give another dose of Tdap. Rabies vaccine, vaccine type, 2 types, the purified varicella rabies vaccine and the purified chick embryo cell vaccine. Recommendations for pre-exposure prophylaxis, these are the individuals to be given. And for post-exposure prophylaxis, you should know this by heart, the categories of wound. For category 1, no vaccine or RIG vaccine needed. For category 2, start vaccine immediately. All category 2 exposures on the head and neck areas should be managed as category 3. And category 3, start vaccine and rabies immune globulin immediately. In all categories, wash wound with soap and water. Schedule for pre-exposure prophylaxis, day 0, day 7, day 21 or 28. Typhoid fever, we have only one available, the purified B1 capsular polysaccharide vaccine, TY21, which is an inactivated vaccine. The oral one is the live vaccine. Recommended to immunocompetent adults living or going to endemic area. Personally, I don't give typhoid vaccine to my adult patients here in the Philippines because we are endemic area. Still, sanitation is the most important factor to prevent typhoid fever, not routinely given to laboratory workers, intimate contact, or during outbreaks. Schedule single dose. Revaccination every 3 years. Varicella vaccine, live attenuated strain, VZV Oca varicella virus, should be given to healthcare workers without history of varicella, should not be given routinely to immunocompetent adults, not to be given to HIV-infected adults regardless of their immunogenicity. May be given as post-exposure prophylaxis within 72 hours of exposure, and may be safely given to patients who underwent hematopoietic stem cell transplant. Schedule is 2 doses given 4 weeks apart subcutaneously. HIV patients with CD4 count more than 200 may be given 2 doses unless they are severely immunocompromised. It's contraindicated. Can a household contact with pregnant woman receive varicella vaccine? Definitely yes, because the household contact should receive the vaccine if susceptible. By vaccinating the household contact, this will prevent varicella infection in the contact and thereby preventing varicella infection in the pregnant woman. One of the best benefits of immunization is the herd immunity. You can see in this graph, the blue ones are the susceptible. They are susceptible because they have not received vaccination, or they have received vaccination but did not develop immune response, have not received vaccinations for other reasons. And if one of these person is infected, so it can now infect the susceptible or individuals, population. If the vaccine coverage is below the threshold for herd protection, then the infection can still infect the susceptible individuals throughout the population except those who are vaccinated. And the threshold for herd protection is, depending on the disease, for measles, it should be 90%, and for influenza, as low as 40%. But if the vaccine coverage is above the threshold for herd protection, you can see in this graph that almost all the susceptible individuals were protected by those who are vaccinated indirectly. Challenges in implementing immunization program. Vaccines only work if they are used. Vaccine hesitancy or loss of confidence refers to a behavior to delay the acceptance or refusal of vaccine despite the availability of the vaccine. There are factors that influence this vaccine hesitancy. Confidence is number one, lack of confidence in the efficacy and safety of the vaccine and the system of policymakers. Loss of trust in the vaccine provider, healthcare workers. 2 is complacency. They perceive that they have the lures of acquiring vaccine-preventable diseases, so no need of vaccine, feeling healthy naman ako. Or some have long-term health problems that they are, if vaccinated, the vaccine may overwhelm their immune system. Kaya natatakot sila. And third is your convenience. Is there availability of the vaccine palagi? Is it accessible? Does the appeal of the immunization series, kasi pag 3 o 5 series ang vaccination, mahirap bumalik doon sa lugar ng vaccination, including the time, place, language, and cultural context, and the access to the vaccine with huge inequity, limited to varying degrees in different regions, the absence of infrastructure to deliver the vaccine, the lack of convenience vaccine provision to families wala akong pambayad, wala akong pamasahe, wala akong ang tagal-tagal, ay magugutom ako. So, or the financial resources to purchase the vaccine, national, local, or international levels, and the capacity of cold storage. This presence of the anti-vaccination movement or the anti-vaxxers. Kasi itong nangyari dito, sa Dinvaxia vaccine, that's why the vaccine acceptance is very low because of that. For misinformations, fake news, and others. So it is causing a worrying trends of decreasing vaccine coverage. Much is written about the dangerous role of social media and release of research engine in the spread of misinformations about the vaccines. So what should be done? Present vaccine as a default approach as early as possible. Buntis pa lang yung pasyente, kausapin mo na kailangan itong anak mo pag pinanganak ay maraming vaccine na gagamitin at habang lumalaki. So ganyan, para alam na kaagad ng mga magulang. Kasi ang vaccine hesitancy is on the part of the parents at this point in time. Education, continuous improvement of training of vaccine providers, better information by enhancing community engagement in a transparent consultation process on scientific expertise, efficacy, safety, public health issues like supply of vaccine and various benefits from vaccination, improvement of trust in the healthcare system and health authorities, improved infrastructure like having a novel delivery platform to eliminate cold storage, and build trust on parents and patients by being honest about side effects when asked. For the anti-vaccine group, the scientific community should provide transparency about existing knowledge gaps and strengths to overcome them. Ensure effective communication about vaccine and the ability to harness the power of immune system through vaccination. Conclusion, immunization protects population from diseases that personally claim the lives of millions of individuals. Despite the outstanding success of vaccination, there are important knowledge gaps and challenges to be addressed. The scientific challenges, like complete understanding of the immune mechanism protection and socio-political barrier, stand in the way of safe and effective vaccination for all. Does vaccination or does vaccine saves lives? The answer is both. Because if you have vaccination, but you don't have vaccine, you don't save lives. But if you do vaccination, by giving the vaccine, it saves lives. Thank you.
You may now proceed to our industry-sponsored symposia. Please go to www.tiktok2021.com and click on the room you would like to join.